Hello everyone and welcome to this afternoon's webinar titled Inclusive Mental Health Services for People Living with Psychosis, the ENRICHED Project. For those who don't know me, my name is Pascal Navele. I'm a research practitioner with the Lambeth Health Determinants Research Collaboration. A few housekeeping rules before we commence the session. The webinar will last for 60 minutes and will be recorded. Slides and other resources will be shared after the session. Our speakers will present for the first 40 minutes, followed by questions and answer session. For effective time management, please type your questions in the chat during the presentations. The speakers will respond after all the presentations are complete. This afternoon, we will hear from the researchers based at King's College London, Helen and Dionne, who will present on the findings from the ENRICHED Project. Jay will support with the questions and answer session. They will speak about the importance of social inclusion for people living with psychosis and how mental health services can better address social and economic needs. We are also joined by Mark and Anikó, who manage services within South London and Maudsley NHS Trust, prioritizing these needs for people living with mental ill health. I'll now hand you over to our first speaker, Helen, to take the space. So Helen, happy for you to start. Thank you.
Great, thanks very much, Pascal, for the introduction. I'm Helen Baldwin. I'm a researcher based at King's College London and just will be starting the presentation. And as Pascal said, we're going to hear from Dionne, Jay, Anikó and Mark today as well. I'm going to be presenting on some key findings from the ENRICHED Project, which we've kind of been wrapping up outputs for this relatively recently. But very broadly, this project aimed to work towards more meaningful social and economic inclusion for people living with psychosis. And I'll overview some of the key findings from this work today. So I'll just start with a bit of a shared definition of what we mean by social and economic inclusion. And I think this is quite a broad term that could encompass a whole range of different domains. But just a few examples are on the right-hand side here. So we were thinking a lot about things such as financial security, access to welfare, more stable and quality housing, good social connectedness, access to employment and vocation opportunities, access to education, hobbies and interests, etc. And I'm sure there's many other ideas that come up as well when we think of social and economic inclusion that aren't listed here. But we know that some of the social and economic needs are particularly heightened amongst populations living with mental ill health, respective to some of these domains. And we know specifically that these may be particularly affecting people living with psychosis. And so I've taken a couple of key statistics from the literature just to recap. The references are in the bottom right corner if you want to read in any more detail. But recent literature suggests that around 80% of people living with psychosis report feelings of loneliness. Around 65% of people experiencing a first episode of psychosis are unemployed in the month prior to first accessing services. And around 80% of people living with schizophrenia have been classified as living below the poverty line, sadly. So I think this shows quite how pervasive some of these social and economic needs are amongst populations living with psychosis and how important it is to address some of these social determinants of mental health. And as I say, I think this broadly affects people living with mental ill health, but is particularly pertinent within the context of psychosis, because we know that accumulating social adversities can confer initial risk for onset of psychosis. And then once psychosis has onset, we know that social and economic needs are typically more heightened, and that our existing mental health services are largely delivered in line with more of a biopsycho approach than a biopsychosocial approach. So with primary intervention being offered usually around kind of antipsychotic medication and psychological interventions. And I think altogether this kind of leads to basic needs remaining unmet, which further worsens social exclusion, further worsens mental health, and leads to poorer long-term outcomes, including things like rehospitalization, and the kind of cycle starts again. And so I think this, really clearly shows that we need to be better addressing social determinants to interrupt this cycle. And although people living with psychosis already represent a vulnerable population in society, we know that there are subpopulations within this group who may experience further marginalization or minoritization. And so people from more marginalised communities living with psychosis are generally less likely to receive existing services such as CBT, family intervention, etc. And we know that social and economic needs may be further heightened or more nuanced within these groups. Where intervention is available, for example, in the form of pharmacological treatment or psychological therapies, these tend to work less well for people who are experiencing socioeconomic adversity. And altogether, I think this creates a sort of lack of trust in mental health services and contributes towards a disengagement from mental health services. And again, ultimately leads to poorer long-term outcomes, including things like rehospitalization and sadly, potentially premature mortality. And so this brings us to the kind of key question that was running throughout the ENRICHED project of how can we develop and deliver mental health services for people living with psychosis that really do prioritise social and economic inclusion. And this project was informed throughout by the Enriched Lived Experience Advisory Board, and this included people who had experience of delivering mental health services in South London, including community organisations, people who had experience of accessing mental health services or supporting family to access care, as well as academic experts in particular topics around social and economic inclusion. And we use a range of different research methodologies to address these questions. So we conducted systematic reviews, we analysed electronic medical records, we sent out surveys to local services, and we conducted community workshops. And I'll go into each of these in a bit more detail now. But to start with a bit more of a global context, we conducted 2 systematic reviews to gain a greater idea of kind of what the global landscape is at the moment respective to social and economic interventions. And we had 3 particular questions that we wanted to address. So firstly, what interventions exist which primarily aim to address the social or economic needs of people living with mental ill health more broadly? Second, does effectiveness of these interventions differ on the basis of socio-demographic characteristics? Third, what types of targeted social or economic interventions exist for marginalised or minoritized communities who are also experiencing mental ill health? And we looked through a whole range of academic databases and registers, and this figure just shows the flow of literature through the study. So we kind of screened all these records and then looked at the ones that met all the criteria. And altogether, we included 266 different studies which kind of evaluated intervention that aimed to address social and economic needs for people living with mental ill health. So quite a broad range of literature that was included. And very broadly, I'll just show some of the key findings. So this histogram on the right shows the different types of social or economic domains that we were interested in. This axis shows the number of studies that were included and then over time. So you can see that we looked at literature from the 90s all the way up to sort of modern day. And there were some particular domains that had received relatively consistent research interest. Lots of them had kind of sharp increase over the last sort of 10 years or so. So, for example, you can see that the social connectedness and social skills domain here has received quite a lot of research interest more recently. Lots of interventions that are aiming to address social connectedness in people living with mental ill health. We also saw that there's been relatively consistent interest in interventions addressing employment with a particularly sharp increase in the last 10 years. And I think a lot of this literature is pertaining to the individual placement and support model of care, which has had quite a good degree of replication within the literature base. Similarly, the housing domain here has had pretty consistent interest, again, quite sharply increasing recently. And I think, again, this is in relation to the housing first model of care, which has received quite a lot of replication across lots of different countries and contexts now. But you can also see that there are areas that have received little to no research interest. So, for example, we can see that interventions pertaining to debt and finance haven't been too sort of widely published on. Interventions relating to trauma and victimization, for example, we haven't seen much literature on this topic. And so that gives a kind of broad overview of the types of interventions that were included. But I'll come back to that second research question. We were interested in seeing whether the effectiveness of these interventions differs on the basis of different socio-demographic characteristics. And this was really quite difficult to determine, owing to the fact that a lot of these publications sadly don't report basic socio-demographic features, including things like race, ethnicity, sex, gender, and socioeconomic status, which makes it really difficult to identify what works for whom. But where we did see this data better reported, and we started to look at kind of interaction effects on different interventions, there was a trend towards interventions generally working less well for individuals who had fewer socioeconomic resources. And so these interventions are specifically developed to help people with social and economic needs, but aren't reaching the people who need it the most, sadly. And this brings us to the idea of targeted interventions. So we then went through those 266 studies and pulled out any research that was relating to interventions that had been either developed specifically to work with a particular community or adapted from existing interventions to better fit the needs of particular communities. And on this graph on the right, sorry, I've missed the labeling on the axis, but you can see these are the different communities that we identified interventions for. So there was a huge range of literature that was addressing interventions for people experiencing homelessness or unstable housing. And again, that's largely due to the Housing First literature. But there was also a handful of papers each that were addressing communities who, for example, had a history of offending, mothers, people experiencing specific economic disadvantage, caregivers, older adults, people from minority ethnic communities, women with a history of domestic violence, and people with comorbid intellectual disabilities. And so you can see that this literature is pretty sparse for these other groups, but it was also quite disparate. So there were lots of just sort of one-off interventions that had been evaluated in the research literature, which means that it's quite difficult to build a kind of replicated evidence base to really determine which interventions work best for these communities. But having said that, all of the identified interventions did report either effectiveness or utility on at least one social or economic outcome. And so I think this really starts to show that potentially targeted intervention to these particularly marginalised communities may be good at kind of addressing some of these pervasive inequalities that we see in mental health care. And that's kind of a broad brush overview of some of the key findings from the systematic reviews. They have both been published relatively recently in psychological medicine and social psychiatry and psychiatric epidemiology. And I think the links for these are going to be circulated after the webinar if you did want to read into these in any more detail. I think there's just a few kind of considerations to keep in mind whilst you're reading through these. So first of all, whilst we did take a kind of global approach to these systematic reviews, a huge predominance of the research was conducted in a few select high-income countries, so the USA, UK, Canada, for example. This might be because we screened particularly for English language records and may have missed some kind of important contributions from non-English speaking countries. So just to keep that in mind. Second, we screened in for populations who had experienced a access of mental health services or had a diagnosed mental health disorder. And I don't think all kind of research fields structure their literature in the same kind of framework, diagnostic framework. So, for example, social care literature may report interventions and evaluate interventions on the basis of social circumstances rather than diagnoses. And it might be that we've missed some important literature there as well. And then finally, just wanted to touch on this topic of epistemic injustice and really questioning who actually gets to contribute towards the literature base. And I think a lot of really important contributions that are made by the voluntary sector, for example, and peer initiatives, we might see more of those evaluations in the grey literature as well as the research literature, which we didn't get a chance to kind of evaluate over the course of this project. So just to keep those points in mind. And so that's kind of a global overview of the current state of social and economic interventions in the field of mental health. But this project was funded by the Maudsley charity, so I was particularly interested in what's actually happening here in South London and the local context. So we wanted to assess what local need looks like and current provision. So I'm going to hand over to Dr. Dionne Laporte now, who's going to give a bit of overview of some of this mapping work.
Thanks, Helen. So as Helen previously mentioned, so psychosis has been linked to a number of different health outcomes. So things like poorer physical health, lowered life expectancy, and more frequent involuntary hospital admissions. Psychosis prevalence has also been found to vary depending on where people live. So prior research has shown that factors such as neighbourhood deprivation and population density have been associated with psychosis. So essentially, what we were hoping to do was to think about or identify, well, are there areas within these 4 South London boroughs where there are higher levels of psychosis and voluntary admissions, and can this help highlight where demand for care may be the greatest? So essentially, we were looking to see whether there was geographical patterning across the 4 boroughs served by the South London and Maudsley Trust, and whether neighbourhood level factors were linked to involuntary admissions or psychosis prevalence. So essentially, with the help of the data extraction team at the South London Maudsley Biomedical Research Centre, we were able to identify just over 15,000 participants with psychosis. And with that de-identified patient data, I was then able to link it to a number of different neighbourhood level indicators, including area deprivation and social fragmentation. And then I also looked at those associations across the 4 boroughs served by the SLAM NHS Trust, which include Croydon, Lewisham, Lambeth and Southwark. So the methods used this analysis, so we calculated the age and sex standardised prevalence of psychosis within those 4 boroughs using a primary care population from the borough of Lambeth as the reference population to make those calculations. I then went on to visually map the prevalence of psychosis and the involuntary admissions across all those 4 boroughs. And then using hotspot analysis, I used that to basically see where there was significant clustering of psychosis prevalence and involuntary admissions across those 4 boroughs. And finally, using regression models, I was able to assess which of the neighbourhood level factors were associated with psychosis prevalence and involuntary admissions. Next slide. So here is the first of a couple of these maps. So the figure 1 that you can see here is the map of those 4 boroughs. And I have just visually mapped the standardised psychosis prevalence against all 4 of those boroughs. So lighter coloured areas indicate lower than expected rate of psychosis compared to the Lambeth primary care population. And the dark colour areas indicate the opposite, i.e. that there was higher than expected rate of psychosis compared to the Lambeth primary care population. And if we were to just quickly look at the borough of Lambeth, for example, we can see that there's quite a few areas that have been indicated as having higher than expected rate of psychosis. And these areas represent parts of Brixton North, Herne Hill and Oval. And there are a couple of areas with lower than expected rates, the lighter coloured areas, which indicate parts of Clapham Common and Streatham Hill. More interestingly as well, so down in Croydon we can see there's quite a bit of so the further north you go in that borough, the higher the rates of standardised psychosis prevalence, and the further south you go into areas like Selsdon and Sanderstead, we can see that the psychosis prevalence was a lot lower compared to the primary care population. Next slide. Here, so this is a map of the distribution of involuntary admissions across all 4 boroughs again. And again, so the lighter colour areas indicate a lower prevalence of involuntary admissions per 1,000 population, and the darker coloured areas indicate higher prevalence of these admissions. And as we can see here, so there is a similar patterning as we saw compared to the map with the distribution of psychosis prevalence, in that if we were to look in the borough of Lambeth, for example, we can see that there are higher than expected numbers of involuntary admissions within the areas of Herne Hill and Brixton North again, and there's a slight clustering of areas with lower than expected involuntary admissions in parts of Streatham Hill and Streatham St Leonard's. Next slide. So we can see, just comparing these 2 maps, we can see that the spread is roughly similar in that the distribution of standardised psychosis prevalence and involuntary psychiatric admissions are sort of similar. But what I wanted to go on to do next is to see whether those patterns, those clustering that we can see here, are significant. Next slide. So this now indicates the hotspot analysis conducted with the psychosis prevalence against all 4 boroughs, as we can see in figure 3 on the right-hand side. And what we can see here, if we were just to focus on the borough of Lambeth, we can see that there's quite a high clustering of areas with a higher psychosis prevalence, largely located within the north of that borough. So again, places like Brixton North, Herne Hill, Oval, and other areas going closer towards the River Thames had a higher expected rate of psychosis prevalence than other areas within the borough. In Croydon, we can see kind of a bit more of it's a slightly different clustering in that Lambeth didn't seem to have any cold spots, but Croydon, most of their cold spots tended to be located towards the south of that borough, and so, the higher standardised psychosis prevalence tended to be more clustered in the north of that borough. Next slide. So again, I use hotspot analysis to look at the clustering of involuntary inpatient admissions across the 4 boroughs again. And similar to, well, not quite the same, although similar to the hotspot analysis for the for psychosis prevalence, we can see Lambeth, there's quite a large area located going towards the north of the borough, where we can see a clustering of higher of areas with higher that should say not prevalence, but involuntary psychiatric admissions there. And again, we can see sort of similar patterning again in terms very striking pattern in Croydon, where we can see that those cold spots tend to be more clustered in the south of the borough compared to the north of the borough. Next slide. And so I then went on to conduct regression analysis, looking at just assessing which of the neighbourhood level indicators were associated with the standardised psychosis prevalence across all 4 boroughs. And within these regression analysis, what was found or what was indicated was that those patients who were living in areas with a higher population density, areas with higher levels of deprivation, areas with greater social fragmentation, which is areas that are deemed to have lower levels of social cohesion among neighbours, and higher population turnover, for example, was also associated with higher standardised psychosis prevalence. Areas with higher crime levels and areas with higher proportions of ethnic minority residents was also indicated to be associated with standardised psychosis prevalence. Next slide. Interestingly, so I went on to look at the regression models for associations between the involuntary emissions and these neighbourhood level indicators. And what the regression analysis indicated was that most of these neighbourhood level factors, such as deprivation, reports of crime within the area level, was not associated with inpatient psychiatric admissions, bar one, which was that those who lived in areas that were more socially fragmented, those areas that are deemed to be less socially cohesive, was associated with a lower risk of involuntary admission. In thinking about this particular finding, it was wondered whether those who lived in those more less socially cohesive areas might not be picked up as well by services, because with the lack of social cohesion among residents, it may be that lack of social cohesion means that people are less aware of the needs of their neighbours, particularly if there is a risk of psychosis, and therefore are less likely to be admitted to secondary mental health services such as the South London and Maudsley Trust. But that was just one sort of pondering that we had as to why that association came out with this particular inpatient involuntary admissions. Other individual level variables or socio-demographic characteristics seem to have a greater effect than some of those neighbourhood level characteristics. So, for example, female patients tended to have a higher likelihood of being involuntarily admitted than male counterparts, and those who identified as belonging to an ethnic minority group also tended to have a higher likelihood of being involuntarily admitted. Next slide. And so just to end on a couple of reflections and things that we could think about on the back of some of the findings of this research, perhaps it might be that we think about having targeted early interventions, such as community-based screening in some of those neighbourhoods that have been identified as a hotspot for psychosis and involuntary admissions. Another thing that we could think about is how we allocate some of those resources proportionate to that neighbourhood level need. Although we must bear in mind that with any geographical analysis, it doesn't necessarily mean that all people with a higher risk of psychosis or being involuntarily admitted will live in those areas with higher needs levels. So we kind of need to be thinking about how do we balance those needs across both neighbourhoods and at the individual level. We could also be thinking about how we monitor those ongoing changes in mental health, particularly among Lambeth residents, whether it be using geographical methods such as hotspot analyses or other methods just to continue monitoring that change. And lastly, thinking about addressing some of those more upstream determinants of health and thinking about how the neighbourhoods or the context in which we live in impact our health. So thinking about addressing housing, employment, or even access to state benefits. Thank you. So I'll hand back to Helen now.
Great, thank you, Dionne. And yeah, so with a clearer kind of understanding of where the need is in social London, I think that really also nicely demonstrated that we need to be better addressing at some of these social determinants within mental health services. We then wanted to assess what the current context looks like in South London, so how well different social and economic needs are currently assessed and how well they're addressed. So we sent a survey out to lots of different community and inpatient teams within South London to see how each of these different social domains that I've listed on the right here, how well they're assessed in practice. And so we were kind of relying on kind of snowballing word of mouth methods to get the survey out to as many people as possible. But we received 28 responses from staff working across both community and inpatient teams. And they gave us a bit of an idea of how well each of these different social domains had been assessed in practice. So where you see this kind of more orangey, beigey kind of colour, this is where these social needs were either always or often assessed. So you can see that things like family functioning, social connectedness, for example, tend to be better assessed in practice. Whereas where you see this kind of bluey green colour, this is where social economic needs were either sometimes or never addressed more often. So we can see, for example, things around education, the experience of trauma or victimization, income and debt. These tend to be the areas of social need that aren't as well assessed in practice and potentially need some kind of room for improvement there. We don't have time to get into each of the domains in lots and lots of detail today, but we did then go through each of those and ask, so how well are they assessed, but also what kind of provision is currently available? And we got a whole list of things back from everybody as to what kind of support was available for each of these different types of needs. And it's fantastic that there was a massive range of support available that's offered by a whole range of teams, including community mental health teams, other NHS teams, local authority staff, and then lots of provision offered by different third sector and charitable organisations. So yeah, really fantastic to see that there is a lot of provision available that addresses these needs, but that this is often offered by quite a patchwork of different teams. And I think from maybe a service user's perspective, that can be quite difficult to navigate when you're seeing one team, for example, for support on housing, another team for support around welfare, another team for support on employment, etc., and potentially requires a bit more sort of wraparound support. This also will circulate a link in case you want to read into more detail about each of these domains. This hasn't been published just yet, but it's available on a preprint server. And so I think this brings us back to the question I asked at the start of how can we actually develop and deliver mental health services for people living with psychosis that prioritise social and economic inclusion. So from the previous projects, we have a better idea of the types of interventions available, where the need is most specific in South London, and what provision looks like at the moment. But how can we go forwards? And this is where the final work stream comes in. So we conducted a series of theory of change workshops, and theory of change is a implementation science framework that essentially develops a bit of a roadmap of a model to show you how you can progress from the current context to your kind of ultimate goal. So we conducted a series of workshops with people who had experience of delivering mental health care or delivering community care, accessing mental health care, for example. And we were really lucky to be working with an expert theory of change facilitator who put this model together for us. So we asked everyone across the workshops what really needs to be done to kind of progress this agenda. And this was the model that was developed. So as you can see, it's quite detailed. I don't expect you to be able to read all of this in detail, but this kind of summarises what our current context is, what our ultimate goal is, and the kinds of activities that might be required to reach certain outputs, to reach certain short, medium and long-term outcomes. And then in blue, we have the ultimate impacts from this. So yeah, this kind of summarises what might be required to reach this goal. We won't have time to get into this in lots and lots of detail today, but there were 6 objective pathways that kind of run through this model that I think all of the attendees highlighted as being integral to this. So I'll just quickly recap those now. But the first was the provision of more person-centred, culturally appropriate care. And we partnered very closely with Black Thrive over the course of this project. And I think they're already doing an excellent job of addressing this first point. Second, we spoke to lots of people who were already offering really great care around social inclusion and economic inclusion, but face really high demand and really long waiting lists. And so it's really integral to advocate for more funding for these existing services that we know are doing great work and offering effective work. But there are also sort of gaps in provision. And so third, attendees were really clear about needing to advocate for funding and support of additional social and peer programmes. Fourth, attendees raised the need for community-based support hubs, and I think recent policy has kind of addressed this as well, but they were very clear about needing both localised community-based support hubs, but also co-located hubs that were kind of both within clinical grounds as well. Fifth, I think everyone was very clear about the need to be able to kind of monitor progress on this topic, and that then needs a sort of shared feedback system, which includes key performance indicators that focus on social inclusion and economic inclusion, so we can monitor development in this area. And then finally, a collaborative community service network in the catchment area. I think this speaks to kind of the point I alluded to earlier around more of a patchwork of services and how can we really begin to collaborate so that we have this community service network in the catchment area. Again, this hasn't yet been published, but is available on a preprint server if you want to read about the theory of change model in a bit more detail, and we'll circulate this after the webinar. But this then brings me on to next steps and what do we do from here and how do we reach this ultimate goal? And I think our ultimate goal is to prevent and break these entrenched cycles of worsening social exclusion and poor mental health among people with psychosis, which we really do believe contributes to these recurring patterns of relapse, readmission and poorer long-term outcomes. And at the end of the project, we asked everyone who'd been involved if they could kind of vote for the 3 key recommendations that they would want to take forward into these next steps. And this is what was raised. So first, as I kind of just mentioned, the development and implementation of key performance indicators to improve data collection around social inclusion so that we can really monitor progress in this area. Second, the integration of social inclusion leads into mental health services whose primary role and responsibility is improving social inclusion, assessing social inclusion needs for service users, etc. And finally, prioritising financial security by offering expert advice on debt and social security. I think a lot of people are very clear about this kind of financial stability being the real foundational building block to then access other areas of social inclusion as well. It would be something as simple as, having enough money to go and meet a friend for coffee and then be able to sort of develop those social connectedness domains as well. And just to end, finally, one of the best parts of this project was being able to kind of go out and see what people are already doing in this area. And we worked with a few services who are already addressing those aims that I just laid out. We're going to hear from Mark at Lambeth Vocational Services in just a moment, who will talk about some of the vocational support that's offered at his service. We've also recently wrote up a piece about this, which will circulate after the webinar, so you can read in a bit more detail. We'll then hear from Anikó at the Southwark Community Welfare Team as to how the service operates in practice. And then finally, just wanted to flag the Culturally Appropriate Peer Support and Advocacy Service, or CAPSA, that's run by Black Thrive, who are doing really great work in this area as well. As I said, we partnered very closely with Black Thrive over the course of this project, and actually kind of in tandem to this research, people at Black Thrive were also doing their own work and looking at the understanding and experience of social inclusion for people from Black African and Caribbean backgrounds, which could be a whole webinar on its own as well. Lots of really interesting findings there. But for now, I will hand over to Mark to provide a bit of a summary of Lambeth Vocational Services.
Thanks, Helen. My name's Mark Bertram. I founded Lambeth Vocational Services and I've been evolving and learning for 16 years with the same team. And we've engaged thousands of people who are in contact with secondary mental health services. During that period, we've done quite a lot of research, evaluation, we've published quite a lot. We've recently worked with Helen's team to produce more evidence. Next slide, please. Yeah, so at the moment, we've got 3 core projects. We've got Vocation Matters, which is unusual because it's a service user run social inclusion support service. And I'm going to talk a little bit more about what they do and their approach. Then we've got Clean and Care, which is a work training project which uses public sector procurement as a catalyst to address the social inclusion agenda. So we do that by partnering with Lambeth Council. So we clean all of the libraries in Lambeth Council, we clean all of the health buildings in South London and Maudsley. We just started gardening and we're attending to the plants at the town hall in Lambeth now. These are pictures of some of the people on our work crew. And we pay people £14 an hour, and all the money that we generate, we contribute back to the project. So we generate about 100,000 a year using public sector procurement. The last one is the COIN project, which is very interesting because it's a dedicated directory of social inclusion resources hosted by 2 peer workers. We've recently gone onto the wards and working with the OTs. Basically, these people know exactly what's out there and they research it and update the directory. Next slide, please, Helen. Yeah, so over the years, our research and evidence indicates that if someone's in a social inclusion support process, they're more likely to feel positive social connections. They're more likely to experience a sense of belonging and less isolation. Good example from our study was someone said, I open my curtains now. So it gives you an indication prior to that person didn't open their curtains. So if someone's engaged in that process, they're less likely to be admitted. About 98% of the people we work with do not get admitted. So that's a staggeringly good ratio. People are less likely to commit suicide. They're more likely to be discharged from community services and end up as citizens rather than as service users. So we do the work for the whole process, and that can take anything from 3 months to 5 years. So it's quite a long process for some people. And then the key thing is that when people achieve a vocational goal that they choose, they're more likely to feel better. They feel hopeful, they feel better, they feel alive, they feel valued, they feel happier. All of these important subjective feelings that, enhances quality of life and promotes mental health and well-being. Next slide, please. Thanks. So how do we do this? I mean, I'm going to have to skim through this, but we've written a lot of papers on what we do. In short, our building is in Stockwell. You come through the door, it's friendly, there's no bulletproof windows, there's no signs telling you to wait or do not this, do not that. People on the reception are service users themselves who are volunteers. You come into the building and it's got lots of plants, it's like an art gallery, it's got rugs, it's got tables, it's the kind of place that feels friendly and warm and welcoming. That's what people tell us. So it's ordinary. It's not like, bright spotlights, clinical eyes, CCTV is on sort of stuff. We don't have any CCTV. So anyway, building bridges of trust is central to everything we do. These quotes come from the Vocation Matters service people. I'm gonna quote two things they said. When I asked them how do they do this, they said what they do is at the outset, we do not use assessment forms, we don't use referral forms. Our aim is to build effective and empowering working relationships which facilitate personal growth, resilience and increased well-being. Then at the first meeting, Sean says, during this meeting, we follow no set pattern or routine. The only routine we follow is no assessment forms are to be filled out by service users or staff. And that the trick of this is to allow the service user to have control of this meeting, as this is not ordinarily the case. So it allows a stronger working relationship to start from the outset. So they kind of like approach things in a pure, natural, person-centered way. Build trusting relationships, not assessing people. Then the key to this intervention is to go at a person's pace. It's no good coercing anyone or going too fast. During that process of exploring person's interests or goals, these emerge over time when someone feels safe in a trusting relationship. The other key bit that you've got to do is know what's out there. So this is where the COIN comes in. We research every week what is out there, what's going on in Lambeth, how do people access it, and we offer people a range of accurate information. The final point here is to respect refusal. By that I mean we don't do any coercion. If someone says they're not ready, they don't want to engage, we respect that refusal. We keep the door open and say, okay, if you feel like you want to come back, here's our number, give us a ring. And that often happens and works. Next slide, please. Thanks. Yes, so the final slide is, these are quotes on the right from people in our study, our qualitative study, and this is what they're saying. If you can read yourself, it's an impression that the base feels comfortable, feels welcoming, it feels calm. There is definitely a pathway to social inclusion, like someone says here. They've gone from not going out, feeling hopeless, to volunteering, getting skills and achieving employment. The next bit is about restoring purpose and identity, and I think this is really critical to it because it's about what someone says here. What did you do today? I'm coming alive again. So I think that's one of the most powerful things that we've found, that what people want as a life and to feel alive. And then this happens through holistic person-centered support, as the person says here. Vocations Matters saw all of me and gave me space to address everything. So that's it really, we do everything. And our outcome ratios are very high as well. So that's our work. And if you want to come and visit us, you can always contact Helen, and I'd be happy for people to come along and visit. Thanks, Helen.
Great, thanks very much, Mark. Yeah, it's really nice to see how some of these recommendations work in practice as well. And similarly, I'm going to pass over now to Anikó, who runs the Southwark Community Welfare Team, to provide a bit of an overview of this service in practice.
Hello, good afternoon all. My name is Anikó Ajozi, and I'm a mental health specialist welfare benefits advisor. I am employed by the South London and Maudsley NHS Trust. And about 3 years ago, I was lucky enough to be able to establish the Southwark Community Welfare Team within the Trust. We are all employed by SLAM, and more specifically from the Southwark Directorate. So this is where our wages come from. And because of these funding reasons, we are serving with welfare benefits advice and casework, the Southwark Directorate's community mental health patients. We are a very, very small team, 5 advisors, and we receive all our referrals from mental health specialists, mental health clinicians within the directorate. It is about 15 community mental health teams. I made the referral very, very easy. It's just a straightforward email. What is the patient's name, trust ID, reason for referral, a letter of authority, so we have permission to contact the patients, and that's it. We have a very experienced advisor who triages the cases, and together with myself, we allocate these referrals to our colleagues, and we carry out initially a holistic assessment, and within this holistic assessment, we don't just look at what was the reason for the referral, but we'll see the person within within their context, i.e. within their family setup. So if necessary, we also give welfare benefits advice to family members, and including, of course, children and carers, if applicable. We have, and now I'd like to direct your attention to this mind map that I created with my team, and it's on display in our office. All of us are together, all 5 of us, in the Maudsley Hospital, and this is where we carry out our casework. It is important for us to be together because we are able to address complex cases together, or sometimes just debrief after a difficult conversation with a service user, or even with a DWP. We are fully integrated within the 15 teams, even though we are physically not there. And it is thanks to all the partnerships that we created within the community mental health teams. We have also, as you can see on the mind map, built health justice partnerships with specialist advisors within job centers, providers of social housing. So we are able to work together with these specialists to provide a holistic care. We also embody trust values through all the items that are listed on the mind map. And I'd like to draw your attention to the middle bit, because our humble tools are maximizing the patient's income and minimizing their expenditure through appropriate welfare benefits advisors. How is this applicable to patients affected by psychosis? For example, when somebody is experiencing their first break psychosis, possibly they were sorry, we're not there yet. Possibly they were, thank you, they were working and all of a sudden they find themselves without any income but bills to pay. So this is where we come in, carry out the holistic assessment, and once the benefits are maximized, then they can be left with about £1,500 in their pocket after paying for their rent and council taxes, to focus on getting better, to attend appointments, to buy vitamins, or pay for activities that they enjoyed in the past, or take up new hobbies. So we believe that through our work, we reduce the burden on the clinical staff, because we are the ones phoning the DWP, holding the line for sometimes an hour and a half before it's even picked up. We are the ones who are guiding the patients through the sometimes mind-boggling ways of how the benefit system works. May I have the last slide, please? I love this picture because this shows that for a very, very long time, things can appear smooth and shiny. Everything is in place. The patient was discharged from hospital. They find themselves in a temporary accommodation. Maybe friends and family help them with basic income. But then all of a sudden, because they were not properly assessed, because the basic income was, the benefits were not applied for example, for housing costs, deep down, these little barnacles can build up. If I could, allowing my IT skills, I would draw teeth to these barnacles, because this is how something unaddressed can go really wrong. And the patient is trying to recover, but then all of a sudden a notice to seek possession lands on their doorstep due to unpaid rent. And this can escalate into the point where even readmission is needed. I'm very happy to take questions at the end. We receive about 300 referrals every year, and this shows the need for the service. Thank you very much.
Thanks so much, Anikó. Yeah, I think that, again, really shows the importance of stabilising someone's financial situation to be able to engage with other aspects of social inclusion as well. Yeah, and Mark and Anikó, as I say, are around for question and answer at the end as well. Just to end with acknowledgements and a huge thank you. Thank you to you all for listening. Thank you to the ENRICHED team who worked on all these different research projects. Professor J. Das-Munshi is one of the co-PIs, who's also available for question and answer afterwards, and Professor Craig Morgan, who's the other co-PI, isn't available sadly, but I can very happy to pass on any questions if there's anything for him. And yeah, just to acknowledge, thank you to the ENRICHED Advisory Board and everyone who kind of supported along the way. As I said before, this work was funded by the Maudsley charity and the ESRC through the Centre for Society and Mental Health. So yeah, just wanted to acknowledge that. And just before we close and move on to the question and answers, just wanted to leave you with a quote from the ENRICHED foreword that our colleague Cassie kindly wrote for us that I think, yeah, really nicely kind of summarises why we need to address these social determinants of mental health to interrupt this entrenched cycle of social exclusion and worsening mental health. Thank you.
Thank you very much, Helen. And thank you to all our presenters for those excellent presentations. We'll now move into our Q&A sessions. Please continue to post your questions in the chat, and our speakers will help facilitate their responses. I think we have a couple of questions in the chat. I'm also mindful of the time. I know we have a couple of minutes to go, and I want to believe that our speakers will be more than happy for us to compile these questions, and then you can respond in addition to the other resources for us to circulate to our audience. So happy for you to still continue to share your questions on the chat button, and then we'll take them up as time permits. So I'll read them as it comes, starting with the first question. The government has recently launched the Connect to Work program to support people who are economically inactive due to having long-term health conditions to gain employment. Do you have any views or reflections from this piece of research that would inform how mental health services could work with local authorities and other partners to better address the economic needs of this cohort and tailor to more appropriate way?
Great, thank you for your question. I don't know if there's anyone that wants to come in on that first. I think, Anikó, you're obviously working in a very relevant area. I don't know if you have any initial thoughts.
My initial thoughts are that in order for somebody to be in a position to look for work and take up work, even voluntary one, in our view, first, the basics, the bottom line of the Maslow's triangle needs to be sorted. So we meet patients at one end of the journey, and the other end will be work. So we create the basis for being well, staying well, being stabilized in the community, and then work towards employment.
Okay. So go to the next question. Sorry, I might have missed this, but what units were the boroughs split into for the analysis or maps, and how was it decided?
Sure, I can go ahead and answer that one. So we divided those boroughs into what's known as lower super output areas, or LSOAs, and these are basically very standard geographic units defined by the UK government, and they're largely used for reporting a range of official statistics such as the census data. So within that study catchment area across all 4 boroughs, I think there was around about 733 of them. We chose those largely because the government data sets and shapefiles are already available for those LSOA boundaries, making it a bit more straightforward to map and analyze geographic patterns in the data. That said, there are limitations with it. So with low super output areas, they are administrative units, and they may not necessarily reflect how the residents themselves define their own neighborhoods. So, I mean, ideally, we would try and capture participants' own perceptions of the neighborhood boundaries and where they go, but that would require separate and more, basically, definitely a more resource intensive project. So those are the reasons why we chose the geographic boundary.
All right, thank you, Dionne. We'll move to the next question. Were you able to test the associations amongst education levels?
Me again. So we weren't able to test for associations with education levels, as that data unfortunately wasn't available in the data set we used, but I definitely agree it probably would have been really useful to include and probably would have added another level of understanding to those analyses.
All right, thank you, Dionne. I'll move to the last question on the chat here. Interested to hear if the hotspot analysis have come as a surprise. Did they resonate with people's experiences on the ground?
I'm not sure if that's a question for me or if that's more of a question for the other practitioners in the room, perhaps.
Happy for anyone to take it.
Can I just say something really quickly? Most of the people who we see who come through our door are suffering from poverty and sometimes from trauma. So in short, it doesn't surprise me if you're poor, you've had no chance to have a decent education, you're more likely to feel invalidated and distressed and be in contact with mental health services. So yeah, to me, it's not a surprise. So if you notice all the nice areas, cold spots as Dionne called them, they're probably nice big houses, nice salaries, got a good life, you know what I mean? So in short, if you're poor, you're at higher risk of being in contact with mental health services, sadly.
Can I add to that? I guess so I'm Jade Das-Munshi. I was one of the investigators on the study, although of course Helen and Dionne led on all of the work. We were sort of involved in kind of advising. I think, and I'm also a clinician, and I guess that the hotspot analysis was surprising, I think. But if you look at the maps, the spots are sort of heading towards the central bits of London. So if you could have a whole map of London, you might find hotspots all around the sort of inner city parts of London. And Mark's absolutely right that these are areas of high deprivation, and this is where we do expect to see more mental health problems and therefore people in contact with services. But there's also something which, you know, goes back decades to this idea of actually these areas having higher levels of sort of social fragmentation, as it's called, that might in some way also feed into what we see in terms of mental health problems. I think Dionne raised the point really well, though. It doesn't mean that there's no need in the other areas. There is actually. These areas are all high need, but there might be even higher need in some of the areas that were sort of highlighted on the map. So I guess we mustn't go away thinking that we can take away services or, you know, provide and move it all into the hotspot areas, because actually all of these areas, certainly in the areas that Dionne was showing in the map, are relatively more deprived compared to the rest of the country. But it's really interesting work that just starts to show how we can sort of think about place-based associations with sort of mental health and service use.
Thank you very much, Jay. We'll take the last question. What was the rationale for looking at involuntary psychiatric admissions? And did you also look at or consider looking at voluntary admissions, and what social factors may have impacted this?
Sure, I can take it, and if anyone wants to jump in, please do. But often involuntary admissions are sort of an indicator of severity clinically, crisis, and a much higher need for urgent care. And that, if we think about it from a government perspective, places quite a high substantial strain on the NHS. So identifying areas with these higher levels of psychosis and involuntary admissions could potentially help pinpoint areas with a significant demand for inpatient care, and perhaps even go on to inform more targeted interventions. But also from more of a human perspective, I mean, involuntary admissions may not be, at least from the get-go, a positive experience for many people who are in need of this intensive level of care. So understanding these factors, and particularly the lesser research variables like social fragmentation and other area level factors that might be associated to these admissions, might help prevent further admissions and inform interventions. I believe the next part of that question was, why didn't we look at voluntary admissions? So within the data set, we had a very, very, very small proportion of people who were voluntarily admitted. Essentially there wouldn't be enough power to do statistical analysis, and it may be misleading if I attempted to do so. And the last bit is what social factors might impact this. Some examples of social factors might be the levels of social support that might play a significant role. So individuals with stronger support networks, such as networks with family, friends, or other connections, might be more likely to seek help earlier and engage with services more voluntarily, and potentially also avoid escalation to crisis. In contrast, those with maybe limited levels of social support may have difficulties recognizing this deterioration in their mental health, and may be less likely to access these services. Other social factors, or more of the upstream determinants that would be worth thinking about, would be things like housing stability, stigma, or even previous experiences with services could also impact these pathways into care. Yeah, that would be my answer to that question. And if I haven't covered anything, Jay, Helen, or others, please do feel free to come in.
All right, thank you. I'm mindful about time, just a minute behind time, and happy for us to wrap up. I want to say thank you to our speakers for sharing their expertise, and all of you for joining and contributing to today's discussion. The slides and resources will be shared after the webinar. If you have further questions or ideas, please feel free to email us, and we'll send that across to our speakers. We hope this session has provided useful insights into developing inclusive mental health services for people living with psychosis. Thank you again, and have a great rest of your day. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye.